condition in the form of cough, rhinorrhea, low-grade fever, and malaise. He sought medical advice and received supportive treatment, but after 1 week, the mother noticed limping in his gait. 2 days later, weakness increased and interfered with his ability to walk. Then, within hours on the same day, he developed severe respiratory distress when he presented to us. He was put on SIMV mode with low settings. All vital data were normal. As regarding CNS, there was disturbed conscious level. Last coma scale before ventilation was 11, then deteriorated gradually over 4 days to be 2/10 post-ventilation. Neurological examination showed generalized hypotonia, almost flaccid, and areflexia, as well as absent sensory level demarcation. The pupils on admission were equal, average size with sluggish reaction, but by the 4th day became dilated, fixed with lost corneal reflex. As regarding CVS, all parameters were normal on admission, but the following days showed tachycardia that reached 170 per minute and systemic hypertension. As regarding respiratory system, there was forced and fine crepitation related to secretion. Other systematic examination was irrelevant. CT brain was done, revealing normal study. CT chest showed bilateral patches of consolidation. As regarding laboratory findings, toxicology screening for pseudocholine esterase and cannabinoids was free. Epidemiology test for polymyelitis in stool was negative. Anti-spike SARS-CoV-2 antibody quantitative test was high. Other laboratory findings were all normal except for total leukocytic count was high, CRP high, serum ferritin, and impaired coagulation profile. And of course, CO2 retention due to respiratory failure. This slide shows the initial CT brain done. Lumbar puncture was done on the 4th day after being hemodynamically stable and after normalization of coagulation profile showing high proteins with 0 cell count. CSF sugar was not consumed. Culture of CSF no growth. Virology panel of CSF was negative. Sleepy EEG showed posterior background of bilateral symmetrical mixed delta and theta waves with no definite epileptogenic activity. EMG was done for both tibialis anterior biceps brachii and right geminoglossus muscle, showing completely absent motor unit potential with addressed activities in the later muscle. Sensory motor nerve conduction studies showed absent responses from nerves of both upper and lower limbs. This slide shows the EEG and the EMG results done. This slide shows the LP results. This diagram shows a differential diagnosis for acute flaccid paralysis according to the site of affection in the motor unit potential. Starting from the anterior horn cell, the nerve roots, the nerve axon and myelin sheath, the neuromuscular junction, and the muscle. This table shows Asper's diagnostic criteria for Guillain-Barré syndrome, from which we have progressive weakness of 2 or more limbs, areflexia, disease course was less than 4 weeks. Other causes of acute flaccid paralysis were excluded. The weakness was symmetrical. There was sensory involvement and cranial nerve involvement. There was typical cytoalbuminous dissociation, and of course we had electrophysiological evidence of demyelination. This table shows how the most common causes of acute flaccid paralysis were excluded. Poliomyelitis was excluded by being symmetrical ascending acute flaccid paralysis with negative stool test for enteroviruses and free CSF virology pattern. Transverse myelitis was excluded as examination didn't show any upper motor neuron signs as hyperreflexia or positive Babinski sign, and with the absence of sensory level and with asymmetrical motor and sensory loss. Heavy metal poisoning and botulinum were excluded by negative history of abdominal pain or ingestion of specific meals. Myasthenia gravis was excluded by presence of areflexia, sensory features and dysautonomia, and also EMG showing abnormal response. Myopathies were excluded by normal creatinine phosphokinase level. On the first day, ceftriaxone and vancomycin were started on meningitic doses. On the second day, oseltamivir and azaclovir were added. Amlodipine was added to control hypertension. On the fourth day, IVIG was given. He also received pulse steroids for 3 days, then regular dose of methylprednisolone on 1 mg per kg every 12 hours as maintenance dose for 2 weeks. Then we started withdrawing it gradually. He was put on vitamin B complex maintenance dose. The possibility to perform plasmapheresis in our hospital was unfortunately unavailable. The patient was in a state of coma, resembling a state of brain death. Although the electroencephalogram showed normal brain function, on the following weeks, while the flaccid quadriplegia persisted, the jaw movement first reappeared after 3 weeks. Then head movement with signs of recovered consciousness resembling a locked-in syndrome. This video shows the early signs of recovery, the jaw movement. This video This video shows the head and jaw movement. We arranged with a charity association to transfer him to another private hospital to perform 5 plasmapheresis sessions. He was transferred on 5th March, where he performed new lumbar puncture, which revealed persistent cytoalbuminous dissociation as proteins was as high as 303, with 0 cell count. He the first plasmapheresis session. After stabilization of the case, MRI was done showing edema and picture of atrophic sequelae suggestive of previous encephalitis. MRA and MRV studies were found normal. The rest of plasmapheresis sessions were carried on later. Over the following weeks, he started to minimally move his hand on stimulation. This slide shows the MRI, MRA, and MRV results. He returned to our hospital on 23 March. He was extubated 1 week later and put on nasal oxygen, then went from oxygen after 2 weeks, and he was discharged on 15th April. The outcome was favorable after long intensive care unit stay and through rehabilitation program. And if it weren't for the prolonged 6 epileptic incidents, which had resulted in neurological ischemic sequelae, outcome might have been better. This video shows his condition post-extubation. And this video shows his condition prior to discharge. Here we notice he can move his hands. Guillain-Barré at a glance. Guillain-Barré is a rare but potentially fatal immune-mediated disease of the peripheral nerves and nerve roots that is usually triggered by infections or stressful conditions like surgeries and can be induced by vaccination. It can be described as a collection of clinical syndromes that manifest as an acute inflammatory polyradicular neuropathy, which will result in weakness and diminished reflexes. All variants of Guillain-Barré syndrome have been demonstrated in COVID-19. The median between the beginning of symptoms and the infection with COVID-19 was 11 days. Mortality is about 3%, while neurological sequelae persistent in up to 20% of cases, half of which are severely disabled. The most common type of Guillain-Barré syndrome is called acute inflammatory polyradicular neuropathy, in which the immune system damages the myelin sheath. In the other two types, calling acute motor axonal neuropathy and acute motor sensory axonal neuropathy, the immune system damages the axons themselves. These are other variants of acute Guillain-Barré syndrome. This slide shows the classic clinical picture of Guillain-Barré syndrome. We also see the picture of cranial nerve involvement and autonomic system involvement. This table shows the 10-step approach for diagnosis and management of Guillain-Barré syndrome. When to suspect, how to diagnose, when to admit to ICU, when to start treatment, treatment options, monitoring, early complications, clinical progression, predicting outcome, and rehabilitation. What are the latest updates in Guillain-Barré syndrome? Scientists are looking at how the immune system works to find out which cells are responsible for beginning and carrying out the attack on the nervous system, and which peripheral nervous system proteins are at great risk of autoimmune attack. A greater understanding of how the immune system damages the peripheral nervous system could lead to better treatment. Researchers are testing now new treatment that can reduce macrophage inflammatory process. Take-home message. Following a Guillain-Barré syndrome mimicking brain death is a rare case which should be considered as a possible diagnosis in comatose patients. It is fundamental to perform electrophysiological tests and CSF studies by lumbar puncture in patients with suspected brain death when the cause is not clearly determined to prevent misdiagnosis this potentially fatal disease. Definitive treatment must be started and early supportive care must be continued, even if signs of recovery are not appreciated or worsening of clinical condition is observed, as most patients have a slow course of recovery that might last for 3 years, and rapid improvement should not be expected. Teamwork of key physicians, nurses, and clinical pharmacists was the cornerstone for improvement of this case after long PQ stay, of course after God's will. Thank you.